And speaking of TGF-beta, we did a trial in the NPRC with AVID-200, which is a compound that is a TGF-beta 1,3 trap, and Andrew treated patients as well on the study. And what we saw there, interestingly, is not worsening anemia, some improvements in hemoglobin, but actually, most notably, improvements in platelet count. And we really have no drugs. Or let me ask you guys, do we have drugs that really, I mean, you mentioned, sometimes the imeds at low doses, even Pamela Amide, when they did the original Pamela Amide study, there was like a 21% platelet, improvement rate there. But do we have any drugs that actually improve platelets?
No, and I think that's actually a great thing to bring up, because when we think about pacritinib and momelotinib and how do we use the JAK inhibitors, none of them can do that. Pacritinib maybe is good at stabilizing or keeping, not making things worse, but very rarely do you see an improvement in platelet counts.
But yet we call it, like
so it's
platelet,
safe for low platelets, but it's not. It doesn't make the platelets better.
And that's a really good point, particularly for the practitioners, because we do have a tendency, myself included, to say, pacritinib is the thrombocytopenic drug. But it's really a thrombocytopenic drug in the sense you can deliver JAK inhibition in thrombocytopenia, not necessarily that it will improve your thrombocytopenia. I have anecdotally had patients where I've had pretty impressive platelet counts, but it takes time. It does not happen quickly. And it's usually associated with spleen reduction and probably better mobilization of platelets. So we don't really have great drugs for thrombocytopenia, which is probably one of the most potent adverse prognostic markers, kind of tracks with thrombocytopenia, with anemia. When you have a really thrombocytopenic patient, the options are quite limited.